by Greg Cosgrove, who is the Chief Medical Officer for the Foundation.
Good afternoon.
So today we thought we would hold an Ask a Doc webinar. We've received many questions in response to prior webinars that we were not able to answer. And in developing this webinar and having you register to be a participant, we've received many of your questions as well. So we're going to go question by question through some of these hot topics and hopefully provide you some very helpful information. So I'm going to start with a question about the registry. Sorry about the slide there. So Greg, let me ask you, we have a care center network that the Foundation has established at over 40 sites in the U.S. And we have also started a biorepository and registry research study at those sites. This has been an exciting event over the past year plus. Can you give us and our listeners an update on where we are with the registry?
Well, first and foremost, before I tell you the fabulous news, I'd like to say thank you because this initiative cannot be done without patients volunteering, the coordinators, the physicians, the nurses, all that participate to help this initiative move forward. So the registry is moving forward at a pace faster than we thought. I don't have the information as of today, but what I can tell you as of yesterday, we were over 1,150 patients have volunteered and participated in the registry. And that is well above our predicted enrollment rate. So that's a testament to the vision of everyone that's participating. And it really provides the opportunity for, now that we have individuals in the registry, for questions to be asked scientifically as well as the clinical questions that a lot of us really don't have the answers to on an everyday basis. And the second half of the question, will we be looking at familial links in pulmonary fibrosis? And that was really part of the scientific question informing the registry. To have a large group of individuals who have lung fibrosis, it now allows us to ask some of those questions about the genetics of lung fibrosis, which is an area of intense investigation by a lot of the collaborators who participate in the registry. But in particular, we actually ask patients when they enroll in the registry, do you have family members who also have lung fibrosis? And so we don't have all the answers yet, but we're starting to understand the role of familial lung fibrosis. And eventually what we would like to do, and as Dr. Lederer mentioned, since we have a biorepository, which are samples of DNA and RNA as well as the components of the blood, we can now test patients and scientifically look for different genetic variants or what we call polymorphisms that might answer some of the questions about why pulmonary fibrosis occurs in families. And there are investigators such as Christine Garcia, David Schwartz, Jim Lloyd, and the group at Vanderbilt, all of whom participate and help guide the registry scientifically and independently are looking to answer those questions. So I think what it demonstrates is the registry is a tool to help guide science and the care of patients, and we do that not as a single entity, but by collaborating with all the great scientists and clinicians throughout the U.S. and the world.
Yeah, there's so much potential with the registry to kind of uncover causes of the disease and even point the way towards monitoring and potentially even therapies. One of the nice things, also one of the other great things about the registry and the care center is that we are going to be able to track how patients flow into care centers, how they're evaluated and managed, and hopefully eventually come up with best practices. Because I think if you talk to 10 or 20 different pulmonologists, even 10 or 20 pulmonologists who regularly see people who are living with pulmonary fibrosis in their practice, you're going to get a lot of different answers about what's the best way to evaluate folks and manage them. What do we do with oxygen? What do we do with pulmonary rehab? What do we do with antifibrotic therapy? There's a lot of missing information medically for us We don't know what to do. We all do what we think is best, but that doesn't mean that it is the right thing to do. So we're going to learn a lot. Also in the registry, one of the strengths here is as far as I know, is the first large multi-center registry that includes not just folks with idiopathic pulmonary fibrosis, but other forms of pulmonary fibrosis as well, including hypersensitivity pneumonitis and autoimmune diseases like rheumatoid arthritis, scleroderma, Sjogren's syndrome, and other interstitial lung diseases of unknown cause, right? IPF is not the only pulmonary fibrosis of unknown cause, something that is, of course, a confusing thing to many.
And Dave, one last comment is that while our initial goal is to enroll 2,000 patients in the registry, that's the first step. We would hope to continue to expand it beyond that 2,000 with additional funding, because then we can answer the questions about some of the more rare interstitial lung diseases. We know IPF is certainly one of the more common ones, and unfortunately there are approved therapies for those that specific disease. But as we heard at the PFF Summit in 2015, pulmonary fibrosis significantly affects other individuals, and so we want to be able to understand other fibrotic lung diseases so we can identify therapies for those patients as well. And hopefully we'll be able to do that as the number increases in the registry. The number of patients with perhaps the rarer forms of lung fibrosis will increase, and then we gain knowledge about those rare diseases, but really important ones that affect the lives of many people throughout the world.
Right. If you add up all of the rare diseases, even rare lung diseases, that family becomes much more common than some common diseases.
Exactly.
Yeah. So you mentioned the summit, and actually before we go to the next slide, maybe let me plug our upcoming summit, which is in Nashville in November of 2017. November 9th through 11th would be a great opportunity to get another update about the registry. There's going to be a lot of discussion about the care-centered registry at that summit. We have patient-specific sessions. There'll be physicians and scientists there as well. There'll be oxygen. So we want to be accommodating, and we'd love if any of you are interested, come to our website, pulmonaryfibrosis.org, and you can get the link to the summit registration website, which is open.
And another comment about that, Dave, is we also heard at the last summit there was a group that wasn't represented well at the summit, and those are individuals who have lost a loved one. They don't have the disease, but they want to continue to participate and add to the community, and that's a new group or track that we have for individuals that want to continue to participate. They may not be interested in promoting the science or other aspects, but they want to drive advocacy, or they want to enhance the networking through patient support groups. And so one of our volunteers, Nick DeVito, is leading that initiative. He has lost his father from the disease and is passionate about trying to find avenues to contribute back in ways that and share his experience. And so that's another pathway for individuals to participate. And we've already had registrants that are interested in that pathway. So I welcome other individuals that could use that sort of track.
Right. And again, you can go to our website, pulmonaryfibrosis.org. Is it Pulmonary Fibrosis? PFFsummit.org is the summit website, I think. Yeah, PFFsummit.org to register. Okay, why don't we move on? We had a couple of questions about the diagnosis of pulmonary fibrosis, and I'm actually very happy that someone brought this specific question up. This is, how is pulmonary fibrosis diagnosed when the presenting symptoms look like asthma, bronchitis, or another lung disease? So maybe let me address this first, and then I'll ask you, Greg. So in my own practice, I would say that the vast majority of patients that I see who have pulmonary fibrosis had symptoms for 1 to 2 years before they were told they had pulmonary fibrosis, and they were initially told that they had asthma or COPD or heart disease or some other medical condition. Now, I will say, I think in the past maybe 2 or 3 years, it's getting a little bit better, and I'm seeing more and more people who are being diagnosed within 6 months, and I'm hopeful that that's a result of increased awareness about the disease. We do have therapies for idiopathic pulmonary fibrosis, and of course, We have immunosuppressive therapies for more inflammatory forms of the disease. So maybe there's greater awareness on the part of physicians that crackles in the lungs and shortness of breath and other things aren't always heart failure. So the critical thing, as I'm alluding to, is the recognition of the disease, and the way that at least I go about educating my colleagues, and of course when I'm training fellows and medical students, is that a careful physical exam, sitting on the doctor's table, the exam table, and listening carefully to the lungs is a critical part of this. So asthma and bronchitis and COPD don't cause crackly sounds in the lungs. That's the recognition part. And asthma can start when you're an older adult, but it's actually fairly uncommon. And so if you're 55, 60, or 70, and you have new shortness of breath, and your doctor says it's asthma, that's possible. But also possible that you have COPD or pulmonary fibrosis. There was a recent study published in a major medical journal called JAMA, or the Journal of the American Medical Association, that looked at folks who were diagnosed with asthma and found that a substantial proportion of them did not have asthma, and that asthma was a label being used to describe different respiratory symptoms. And the same thing stands for COPD. There's a lot of folks who are labeled as having COPD who don't, and instead they have a different respiratory condition, and a substantial number, a minority, but a substantial number have pulmonary fibrosis. And then, of course, there's folks who have both COPD and pulmonary fibrosis. Once the disease is recognized, then the whole diagnostic workup really starts with a CAT scan of the chest, pictures of the inside of the lungs. And that CAT scan has to be done extraordinarily carefully with the correct protocol, or it can give misleading information. That's the cornerstone of diagnosis nowadays. And then, of course, there's other important components, breathing tests or pulmonary function tests like spirometry, measurement of lung volumes, diffusing capacity. We often look for oxygen levels and how they might drop when you're walking around. And then some people need a biopsy of the lung, and that's being done in different ways nowadays. Greg, what do you want to add to that?
I would just say that in evaluating someone with lung fibrosis, once you know they have lung fibrosis, it becomes relatively straightforward. But I think, as the question's alluding to, it's hard because the symptoms are shared, but when you think about breathlessness, it's more of a comprehensive evaluation, as you allude to. You listen to the patient, mostly their symptoms as well as their physical exam, but then you just evaluate those symptoms. So if you're short of breath when you're walking, having them walk down the hall and see if their oxygen drops. That's a helpful aspect that can be done in the clinic, and it likely will help the clinician, whether they're a primary care doc or a pulmonologist or even other specialties like a gastroenterologist. It heightens the concern and facilitates a more rapid evaluation, mostly because most patients with asthma don't have their oxygen fall when they're walking, or there are other key symptoms that differentiate it. So raising awareness is the first step so that it enters the physician's mind when they're evaluating the patient with some of those symptoms. And hopefully, as Dave, you've alluded to, the sooner we make the diagnosis, the sooner we can implement the measures that we know can impact the patient's life in terms of treating the different aspects of the disease.
Very well said. So then the other question, second question, is why does the diagnostic process take so long? And I think we alluded to that. Some of this is the early symptoms look like so many other diseases. And I'll also say that, even before symptoms start, the disease is there. There's an asymptomatic period, meaning a period where the disease is present in the lungs, but no symptoms, no shortness of breath, no cough, or maybe just mild cough that many people have. Maybe it's a cough from postnasal drip or from heartburn, which are major causes of cough. And maybe the shortness of breath isn't showing up because, that person's not exercising, and so not getting to the point where they're short of breath. So the symptoms creep up slowly and are often labeled as something else. Like I said before, heart disease, COPD. I've even had patients show up and say, well, my doctor thought it was because I was overweight. or I just needed to exercise more. And some even, I was just getting older. But aging does not cause shortness of breath. So it does take long in many people. As I've said before, I'm seeing more and more people show up getting, their physician is recognizing the disease earlier. They're getting appropriate testing earlier than before. And I think this trend, I hope it continues. I hope it's not just a northeastern United States thing in my neck of the woods. I hope it's a universal thing. And it's probably something we'll be able to track through the registry if people start showing up with more mild disease over time. That would be a sign that people are getting referred earlier, which is recognized and referred earlier.
And to comment on that too, I think in thinking about it for individuals that walk into a doctor's office with breathlessness, especially when they're walking, if you're 65 years of age, you have a prior history of high blood pressure, and you've smoked, your doctor is most likely going to be concerned about heart disease, because statistically that is a concern in that age group. It's the same age group that pulmonary fibrosis tends to be occurring in, so it does make it a little bit challenging. But I think, again, your doctors are likely thinking about all these issues and they're prioritizing them. So that does lead to some delay. They're thinking of the things that could really acutely hurt individuals, and there is a prioritization of medical care. But I think the sooner they think about lung fibrosis, the faster it gets diagnosed. And I do suspect that's decreasing in the delay, but it's still, we need to improve it.
Yep, I agree. Yeah. So Greg, let me pose this one to you. This question is, what drugs are available to treat or prevent the progression of pulmonary fibrosis, and how effective are they?
Okay. Well, I guess to be specific, there are 2 approved therapies for the treatment of idiopathic pulmonary fibrosis, and so that's one specific disease, in contrast to the other 180 forms of potential forms of pulmonary fibrosis. So specifically talking about that disease in IPF, both medications, pirfenidone and nintedanib, delay the progression of disease. And so what does that mean to a patient? Well, it means that in clinical studies, those medications were able to demonstrate that the breathing test abnormality, the FVC, which is the amount of air you can blow out in 6 seconds, that the rate at which that was decreasing was shortened. And so hopefully that would suggest that the drugs, well, it does suggest that those medications were affecting the fibrotic process within the lung. And that is the first time in this field we've been able to demonstrate that an intervention affects the disease process. Traditionally, we think that idiopathic pulmonary fibrosis progresses in its natural form and unfortunately takes the lives of patients over an average of 3 to 5 years. And so this is the first step to treating this particular disease. And the big question that many patients have, in particular those that have pulmonary fibrosis from another cause, is do these medications work in their specific disease if they don't have IPF? And that's a concentration for not only these 2 approved therapies, but for other therapies to try to understand which medications are available to treat their form of pulmonary fibrosis. Currently, we can't say that either pirfenidone and nintedanib treat other forms of lung fibrosis, but we are certainly hopeful that the studies would suggest that, or that we identify other treatments for those diseases.
Yeah, pardon me. And as you're alluding to, Greg, there are ongoing studies, right, of these drugs, of nintedanib and of pirfenidone, in forms of pulmonary fibrosis other than idiopathic pulmonary fibrosis. They're both actively enrolling. One is, they're both multinational. One of them is not taking place in the United States, but is happening in Europe and other parts of the world. And those studies are exciting and have broad criteria, right? You don't have to have IPF. In fact, you shouldn't have IPF. So a broad range of fibrotic lung diseases, or a broad range of different kinds of pulmonary fibrosis. So my hope is that those studies enroll quickly and we get some answers. And then if these drugs work for other kinds of fibrosis, that would be a second game changer, right? The first game changer being 2014 data that both drugs help slow progression. So the other part of the question was prevention, and this is a common question that I get in the office from family members who come with my patient, often an adult child, more so than, say, a sibling, usually an adult child, who asks the question, could I get this disease? And often it's not asked, but I know it's there, and I bring it up, and we talk about it. Now, there's a question later on in the slide deck about genetics, but maybe we can talk a little bit about it now since we're on the prevention topic. Genetics do play a role. Some proportion of people with pulmonary fibrosis do have another family member with pulmonary fibrosis. Different studies quote different numbers. Some as high as 20%. I don't think that that's the norm. I think the truth is probably lower than that. But it's very hard, or I would say even impossible, to be able to predict what an individual person's risk of developing pulmonary fibrosis is when their parent has it, or not even, right? Either way. But we can't answer that question. We don't have that data. So what can you do if we don't have an answer about your risk, and no one's risk is zero, right? Even doesn't matter. Anyone can get pulmonary fibrosis, infants to the oldest adult, men and women. It occurs worldwide. What could you potentially do to prevent it? So don't smoke. I could say that 10 times in a row to emphasize how important it is. If you do smoke, see your physician to talk about cessation methods. There are some effective ways to quit smoking. I tell people, and this sounds a little funny, I say only breathe air. When my patients say, well, can I be around paint fumes or construction sites? I simply say the only thing you can breathe is air. And so that means fumes, dust, moldy areas. We don't know what causes half of these, half of the cases of pulmonary fibrosis. So don't breathe anything in that's not air, because we do know that breathing in things like mold, exposure to birds, and so many occupational exposures, asbestos, silicates, coal, heavy metals, and others can trigger this. So only breathe air. And then avoid infections. We don't think that things like pneumonia cause pulmonary fibrosis, but if there's a predisposition, then injuries in the lung could lead to scarring in the lungs. Is there anything you want to add to that?
Well, I just might add, so that might be the perspective from a patient that doesn't have a family history. So if we take a different perspective, what if someone walked in the office and they had 3 or 4 family members from the prior generation, and they're otherwise healthy at age 40, what should they do or what shouldn't they do? Should you consider genetic testing or should you not? And what I would say is the issue of genetic testing in pulmonary fibrosis is a very complex one. And so what I would recommend is you discuss it with a certified genetic counselor. They may be present at different institutions. We actually have Janet Taubert, who works with the foundation, and you can contact her through the genetic counseling line is one option. Certainly you can, would recommend you talk to your physician, but it's important to understand the risks of genetic counseling, or perhaps the reason why one would do it. It's still unclear as to how it might help the clinician caring for a patient with or without lung fibrosis, but in certain instances it can be helpful. But what I tell patients, Dave, is that if it appears that there's a risk in one's family, that doesn't mean you're going to get lung fibrosis, but I think as you advocate, you do everything to be as healthy as possible. There's clearly evidence in Mark Steele's paper from almost 15 years ago now demonstrated that in the cohort he followed, tobacco smoking was the single highest risk factor for an at-risk individual for acquiring lung fibrosis. So it's part of our oath as pulmonologists to advocate for tobacco cessation. It's not for any other reason, is that it is really something that can affect you in so many different ways, from your heart as well as your lungs. And in this particular group of patients, it can actually precipitate lung fibrosis. So it's something that's difficult, but with help, as you mentioned, with tobacco cessation, the success rates are very high. So that's just an additive to what you had mentioned, Dave. So I like your comment about just breathing air.
Yeah, only breathe air.
And make sure it has oxygen in it.
Okay, cough. Are there remedies that work for cough? So let me talk about this for a moment. This is, of course, one of the very common symptoms of pulmonary fibrosis. And even outside of pulmonary fibrosis, cough is the most, either the top or second most common symptom prompting evaluation by a primary care doctor. So, of course, we've all had a cough from time to time. Some of us have chronic cough, and pulmonary fibrosis can cause cough, very bothersome cough, typically dry. A lot of my patients complain of small amounts of clear sputum, particularly in the morning. So the way I tackle cough in my patients with pulmonary fibrosis is I first look for other treatable things. And the truth is that there are many people, and I'm speaking from my own experience with my patients, where their cough is not entirely due to their fibrosis. And that the other major contributors that I see are postnasal drip, which we call chronic rhinosinusitis, and heartburn, acid reflux, or GERD, different names for the same thing. And so I will often aggressively treat those things if they're there, or just to see if the cough gets better. I would say the majority of my patients who have pulmonary fibrosis have significant postnasal drip symptoms, and I've seen many people where treating those two conditions has improved the cough dramatically. Usually it's not gone because the fibrosis is still contributing. This does not mean that you should go and start taking treatments for postnasal drip or GERD, but instead you should talk to your healthcare provider and decide if any treatments like those are the right ones for you. I've also found that there are some people, not everyone, but some people, when their oxygen levels go down, they cough. And of course, cough can also trigger low oxygen levels. So for some people with pulmonary fibrosis, using an appropriate amount of oxygen can help prevent some episodes of cough. And after that, it gets a little tougher. We don't really have good treatments. There are some long-standing therapies available that people could try. Some are over the counter. Some are by prescription. Some have opiate-like drugs to suppress cough. Some things work for some people, and some things work for no one.
And I've had this similar experience, Dave, that it's the treatment of cough is probably one of the most frustrating dilemmas for the patient, but also for the physician trying to care for them. There is a lot of research that's gone into understanding why people cough, and there are hundreds of possible reasons why cough is initiated. Over the past several years, there has been that research has led to novel targets and clinical trials, not only in just pulmonary fibrosis, but in asthma and in COPD. So I think it's a demonstration as to the dedication to trying to help patients. Those studies are early in their initiation in terms of phase 2 studies, but hopefully the success that has been suggested in those early studies might deliver a product that can more directly affect and diminish cough, as has been suggested in the early studies. But that's really an exciting opportunity given the debilitation in patients with IPF, but also in a lot of other diseases where cough has really affects someone's quality of life.
Yeah, and I echo that. I think there's a lot of promise in these cough, research studies of experimental therapies for cough. And I agree with you. I imagine having the ability to offer a drug that really, really works for cough would I think, really transform people's lives. So I'm very hopeful. We've mentioned the clinical trials a few times. We've mentioned it about the drugs that were approved, went through clinical trials. There are the ongoing trials of antifibrotic treatments for other forms of pulmonary fibrosis, and we mentioned clinical trials for cough. I just want to mention, it's not on the slide, it's not a question that was given to us, but I do want to mention that you can search for clinical trials on a website called clinicaltrials.gov. I did a search about a month or 6 weeks ago for pulmonary fibrosis trials that were actively recruiting, and I found 40. Yeah, I found 40. So there's a lot. Some are in the U.S., some are outside the U.S., some are multinational, some are early stage, some are late stage, meaning phase 3 trials. The vast majority are phase 2 right now, but worth a look. Can provide important insight and a balanced perspective on transplant. There are international guidelines that recommend the timing of referral to a transplant center. So I use that very specific language of timing for referral, meaning your doctor reaches out to the transplant program or you reach out to the transplant program and ask to make an appointment. And that process is, of course, very different than being put on a waiting list for a transplant. And the referral process, in most circumstances, ideally takes place long before you need to go on a waiting list. When you need the timing of going on a waiting list is when you're sick, when you need a lot of oxygen, when you're very short of breath, when your life activities during the day are limited. But the timing for referral to start testing, to make that visit, can be as soon as you're diagnosed. Even if your disease is mild. Most people with pulmonary fibrosis eventually have worsening of their disease. Some people over a long period of time and others more rapidly, and it's something that's hard to predict. So the guidelines that I mentioned earlier recommend that if you have scarring in the lungs, so idiopathic pulmonary fibrosis or a different kind of fibrotic interstitial lung disease, that you ought to be referred as soon as you are diagnosed. Now there are more nuances to that. There are some more guidance on what lung function test numbers should prompt referral, or whether or not you've successfully responded to some kind of treatment. But in general, these guidelines recommend referral at diagnosis, and I cannot emphasize how important it is to try to get to a transplant center early rather than waiting for progression or waiting for some medical event to prompt the referral. I've seen many patients where the timeline from first referral to listing was 3 or 4 years. And we needed that time to get them through the process. It's a long evaluation process for some people. The waiting time can vary a lot depending on where you are in the country. There's some centers that have a waiting time of 1 to 2 weeks, and other centers that have waiting times of 4 to 6 months, and others where it's longer. So the short answer is now.
And I think being referred and seeking that information doesn't commit one to make any decision. It's part of the process. Some patients find that it is something they're very interested in, and it's motivating for them to perhaps lose the weight that the transplant team thinks is appropriate, or to remain as healthy as possible. Well, what I tell my patients, it's similar to purchasing a parachute. If you're on a plane, and God forbid the plane goes down and you had a parachute and you're the only one, you really look like a genius. But if you have that parachute and the plane never goes down, you've spent some time investing in a parachute, but you never need it. And much is the same, since we can't predict the future for every patient with lung fibrosis. What we want to do is prepare them for all the possibilities, to give them options, and then should things occur where they need to pursue it, they're ready and they're able to. I think both you and I have been in the position where some patients wish they have acted sooner to be referred to transplant, and now they're too sick to undergo the surgery, which is a very difficult situation for them, certainly, and for us as their physicians, because we're trying to advocate for them all the time. So helping patients be the healthiest that you can, and this is a general statement, regardless of transplant, being the healthiest person you possibly can be, being the leanest, is uniformly associated with a better quality of life regardless of the lung fibrosis or not. So I think that's an important step for anyone with any disease, but in particular lung fibrosis.
And I want to add two more things, because I know that not everyone who's listening can get a transplant. So let me say two things about that. One is there are over 2,000 lung transplants performed every year in the United States. About half of those are for people with different forms of pulmonary fibrosis. So that means that roughly over 1,000 people in the U.S. will get a lung transplant for pulmonary fibrosis each year, 1,000. But we estimate that there's well over 100,000 people living with the disease in the United States. So that's about 1 out of 100 people. Now, of those 100,000, some people are very healthy and don't need a transplant. But among those who do need a transplant, they may have other conditions that are barriers to transplant. And for people, I'm not going to go into all the details about who should and who shouldn't get a transplant. We do have an archived webinar on this, and maybe it's time to do another one. It's been a couple of years, actually. But the bottom line is that transplant centers all have different criteria. Some transplant centers might say, no, the risk for transplant for you is too high. And another transplant center might say, come on in, we're going to put you on the waiting list. So each transplant center has their own criteria. And transplant centers, when they say no to you, what they're telling you is they think the risk of the transplant is higher than the chance of you having a benefit from the transplant. And I think, Greg, you've probably been in this situation too, where I've seen people who were worse off after the transplant than they were before. Now, that's not common. Most people who undergo a transplant are better off after the transplant, but it's not right for everyone.
And I think those numbers are sobering in terms of the availability of transplanted lungs. It further emphasizes how important what you had mentioned, that there are 40 trials going on throughout the world. We cannot treat everyone with lung fibrosis with a transplant. So the hope is we identify, in addition to the 2 approved therapies, additional therapies that treat lung fibrosis. And the ultimate goal is that no one would ever need a transplant moving forward if we have additional therapies. So that's the goal. Until then, transplant is very helpful for a select group of patients.
Yeah. All right, so I'm the lucky person who gets to ask Dr. Cosgrove to talk about stem cells for pulmonary fibrosis.
So this is a very frequently asked question, and it is an area that of tremendous promise. So my comments are directed at the ultimate goal of the Pulmonary Fibrosis Foundation is to assist and advance in knowledge, understanding the role of stem cells and cell-based therapy in the treatment of lung fibrosis. As of right now, there are a limited number of studies throughout the world, and in particular in the United States, that have scientifically investigated the role of, in particular, mesenchymal stem cells, which are just one type of stem cell in patients with lung fibrosis. It was a safety study which was coordinated out of Miami with Marilyn Glassberg. It's called AETHER. And that study has recently been published this past May in the journal Chest. And what the specific goals of that early study was a safety study where they demonstrated with the infusion of mesenchymal stem cells, it appeared to be safe in that small group of patients, which was 9 individuals. So that small study is the first step for us to answer the first question of any treatment for any disease, and that is it safe? The second question, once we prove safety, is it actually effective in the treatment of the disease for which it's being used? So in 9 patients, we've been able to, or we as a community, Dr. Glassberg and her team in particular, has been able to demonstrate that it appears safe in those small number of patients. the appropriate step forward is a larger controlled study to understand, again, safety, but also efficacy. So many of you have seen that there are entities for stem cell therapy for a variety of different ailments, whether it be musculoskeletal, arthritis, lumbar discomfort, as well as COPD and pulmonary fibrosis. I will definitively state that there is no evidence to suggest that stem cells have been proven in the treatment of pulmonary fibrosis. Importantly, the safety of those therapies has yet to be defined. And lastly, there is evidence from across our partners in the country that there has been a temporal association with a decline in health with the infusion of stem cells, which we have provided the accounts to the FDA to make sure that they're aware of this issue and can further understand the potential safety risks. And as a community, I believe it's almost 2 or 3 years ago, we came up with a statement about our position on stem cell therapy for pulmonary fibrosis. And that position is we encourage further research and the development of clinical trials so that we can perhaps utilize this tremendously potential type of therapy for the treatment of lung fibrosis. But at the present time, we as an organization, as well as others such as the American Thoracic Society, the COPD Foundation, many other foundations, do not believe that therapy can be recommended by the available evidence. But we highly encourage trials such as Dr. Glassberg's to prove that safety and prove efficacy. And that's what we would encourage individuals to talk about. And prior to seeking any off-label therapy, we certainly would want you to talk to your physician to make sure that they're aware of the situation. Again, it is a tremendously potential, exciting field. It just needs to mature, just like any other therapy that we consider for any disease.
100% agree. I'm going to add a couple things. So one is, how do you know if it's a research study? So you look for 3 things. One is there needs to be approval by an ethics committee or institutional review board. There needs to be an informed consent form that you sign that explains the study in great detail in regular language, not in medical language. And it needs to be free. That means if you're going for any kind of stem cell infusion and you have to pay money for it, it is not research. And that's a fundamental principle of research.
And Dave, maybe I'll make one more comment. You say, well, why might you be a little bit passionate about this issue? Well, if you look at the history of pulmonary fibrosis, we were bound by the lack of therapies when patients came to see us. And so in the absence of having a coordinated network where treatment could be evaluated as part of a clinical trial, the first of which occurred in 1999, that was the first multi-center trial on pulmonary fibrosis. Physicians wanted to help their patients, and so they were willing to use therapies with the idea that they've had 2 or 3 patients that have benefited, what we call anecdotal reports. And that really has guided the field over the past 20 years. Unfortunately, when we actually did the right study and evaluated a treatment called azathioprine and prednisone, we found that that treatment that we had been advocating for over the past 30 years was actually harmful to patients. More hospitalizations, more deaths, and more side effects. And so that is the background why we want to make sure that any treatment that we recommend, we want to aggressively and rapidly evaluate it. And that's what I think another role we have as a foundation is to try to increase efficiency and get the best drugs and the safest ones into the hands of physicians to treat patients. But we need to do it safely so that we're not advocating unproven therapies that have side effects and quite harmful ones.
Yeah, I'm going to add one last thing. So the term stem cells sounds magical to us, that we could take a cell and grow a lung or some other organ. And of course, in an embryo, in a fetus, that is what stem cells do, right? We're all created from a stem cell. The types of stem cells that are being used in research, that are being infused, you heard the word mesenchymal stem cells, a medical term. And mesenchymal stem cells are actually not stem cells that turn into other tissues and organs. In fact, many scientists use a different term. They call them mesenchymal stromal cells because they don't function the same way as an embryonic stem cell or these other stem cells. I'm going to use another medical term that are called inducible pluripotent stem cells. So technically, if you're thinking about this, it's not really stem cell therapy as if it's going to regrow your lung, but these cells might help heal the lung or heal the cells in the lung. At least that's what we would hope. And when I say heal, I don't mean remove scar tissue and replace it with normal lung tissue. I simply mean that the hope is that cells that are undergoing some bit of injury that could lead to fibrosis, that those injured cells could heal. But we don't know. Okay, sorry. That was my last word on stem cells.
Okay. So how do we gauge progression of the disease? And that could be difficult. The disease affects many individuals in many ways, and someone's breathing tests might be mild, moderate compared to another patient, but the symptoms might be discordant or they don't correlate to the breathing tests. But in general, what we do or should do at every visit is assess it in several different spectra. And that is, we ask how you're feeling. We ask what you're able to do, what makes you breathless, what other symptoms you have. That gives us an idea of disease activity. And we kind of put the pieces of a puzzle together where the symptoms are very important. And on top of that, we utilize the breathing tests to give us an idea and compare from one visit to the next. And then perhaps, depending on symptoms, we may have images from the CAT scan that further enlighten that puzzle and clarify the picture. And additional point might be how well or poorly can you walk with or without oxygen? Are you needing more oxygen? All those data elements tell us a little bit more about disease progression. If you think about clinical trials, the one study is really that we count on is the breathing test. And that's what the two drugs were approved based upon. So that's probably the most reliable. But from a clinical standpoint, I think Dr. Lederer and I worry about how it's affecting the patients, their quality of life, and it emphasizes the importance of all the other therapies that we're advocating for. At the end of the day, we want you as a patient to be healthy, not just your breathing test.
Yeah, a lung function number of 78% for one person is something completely different for another person. It's not comparable. Everyone's an individual. And we do look at these things as they change over time, but at one point in time, we can't look at a test and tell you, exactly how severe the disease is for you. So this may be our last question, because we may end up talking about this for quite a while. We received quite a few questions from you, from the folks who registered for the webinar, about what happens when the disease is very severe, what happens towards the end of my life, am I going to suffocate? We heard that word, and here on the screen you can see, am I going to just wake up one morning or suffer with the lack of oxygen or a heart attack? So let me say a few things about that. I would say that in most cases, people with pulmonary fibrosis are not suffering at the end of life. And I think that's because we, along with many other specialists, are able to provide treatments that focus on your symptoms. And the main symptom, of course, is breathlessness. We do have medications that can be used to manage breathlessness, whether that's in the hospital, whether that's in a hospice setting, which is often at home or sometimes in an inpatient setting. We can control most of your symptoms, most of your breathlessness. Now, I'll also say that not everyone with pulmonary fibrosis dies from pulmonary fibrosis. In one study, it was about 60%. And that means the other 40% died from all the things that we all die from: heart disease, other smoking-related diseases, strokes. So just because you have this diagnosis doesn't mean you're going to die from it. I think that's an important piece of knowledge, and when I tell that to my patients, I think it's often eye-opening for them. I think people, when they get this diagnosis, assume that they're going to die from this, but a sizable number do not.
And I think it speaks to the importance and perhaps a change in focus of physicians. When patients were diagnosed, say 10 years ago, there was quite a degree of nihilism where they stopped taking care of their patient because they assumed they were going to die or didn't pay as much attention to the other medical problems. In my experience, I think the reason patients are living longer is we do have treatments for their lung fibrosis, but we're much more attentive to taking care of the diabetes, the heart disease, as well as other aspects of their care. And again, the healthier the patient is with lung fibrosis, the more likely they're going to live longer. And I use the term hospice has a lot of negative connotations for patients because the images that perhaps they've seen are distressing, and I prefer the term palliative care or more appropriately supportive care. And it's clear that what we want to do is support patients regardless how healthy they are. If they need more oxygen or if they are progressing in their disease, the focus of our care is not curative because we don't have those treatments yet, but it's really on helping prevent symptoms to make sure that we're supporting you. Some of my patients, their oxygen requirements in Denver get quite high, and they physically can't walk without their oxygen going down quite low. So I advocate for a motorized scooter. I put a big horn on it, and so they can alert people, but they can get out of the house. They can maintain their quality of life. That's technically supportive care or palliative care. And one of our colleagues, Kathy Lindell, who's actually a board member at the Pulmonary Fibrosis Foundation, has an entire research project looking at the role of supportive care or palliative care, and much as we've talked about with transplant, perhaps initiating that earlier so that we can support patients and help them live longer. In the lung cancer world, patients who receive chemotherapy and palliative care live longer than patients that just receive lung cancer chemotherapy. The reason is because their anxiety, or we think their anxiety, their nutrition, their functional status, physical therapy is all maximized, and that has an important impact in fighting any disease. So I would advocate the same thing we should do in pulmonary fibrosis. And if you have interest or want to contact Kathy Lindell, she's at the University of Pittsburgh, and she's certainly a resource that many of us use, and you certainly could participate in her research as well.
Yeah. And just my last comment on this topic, the main indicator, to address the specific question here, the main indicator of severe disease progression towards the end of life, as Greg mentioned, is the need for increasing oxygen amounts. So many people in early stages of the disease need no oxygen, and with progression might need to use oxygen during sleep or when exercising, and soon after or at some point after begin to need it with routine activities, and eventually need to use oxygen around the clock. And in the last weeks and months of life, at least in my experience, most of my patients begin to need very high amounts of oxygen, sometimes through a face mask, sometimes even amounts of oxygen that are difficult to deliver at home, or that are so high that they can't even get around because their oxygen levels go very low despite using plenty of oxygen. I guess that was my last point on that. So we have time for this. Can you talk more about NSIP, which stands for non-specific interstitial pneumonia? My husband was diagnosed with it, but is currently not taking any medication because his doctor believes he's stable. What should we watch for or expect? So I'm going to preface any answer by saying that we cannot provide any medical recommendations for anyone on this call or on this webinar. Please, of course, talk to your doctor. If you'd like another opinion, you can always go to our website and find a care center that might be near you, or may not, but may be worth traveling to get another opinion. We're only here to give medical advice, medical information. So let me mention NSIP briefly. NSIP, or non-specific interstitial pneumonia, is technically the visual appearance of the lung under the microscope. is a description of the visual appearance of the lung under the microscope, rather than a disease. And I'm probably being a little bit picky here, but the NSIP term really was developed by physicians that are called pathologists. These are the doctors who look at tissue under a microscope to make diagnoses, and they describe this pattern that looks different than the pattern we see in IPF and labeled it NSIP. And then we found patients who have this pattern who don't have any explanation for it. And so we've kind of used that term, either NSIP or idiopathic NSIP, to describe folks who have this pattern under the microscope. And it is like any other form of pulmonary fibrosis. It tends to be progressive over time. If there is inflammation in the lungs along with it, sometimes we'll use medications to treat that. And there are also people who have NSIP in the lung under a microscope and have it from, not idiopathic, but have it from exposure to medications or from some other kind of inflammatory disease like scleroderma or other explanations for it. We can't give any recommendations or advice on whether or not it should be treated. Treatment is appropriate in some people. Treatment is not appropriate for other people. You want to add anything to that, Greg?
I guess it suggests it's probably a greater issue when you think about the lung abnormalities with interstitial lung disease. So whether it's IPF or whether it's NSIP or even if it's an exposure, the discussion that needs to occur is one where the goals of any treatment are evaluated, the likelihood of a benefit from treatment, and also what's occurring over time. So in individuals with scleroderma who have NSIP associated with that disease, they have abnormalities but may not progress. And so one of the more difficult decisions is whether or not the benefits of treatment outweigh the risks. And that's truly what we struggle with as physicians caring for patients, trying to maximize any potential therapeutic benefit versus the side effects. And so I think, as David has alluded to, making sure what your doctor believes stable is, and understanding that, and understanding perhaps why treatment should or should not be expected in that circumstance. I would say stable is a very, very good word. And so that's wonderful that you come to that decision with your physician, but continuing to have a discussion and continuing to be evaluated is a really important part of any form of pulmonary fibrosis.
So we only have a couple of minutes left. I think we've really addressed this particular question on family history, so I'm going to skip through it. And the last two questions, I'm going to summarize pretty quickly so we can get to both of them. One is about weather, and on the next slide is a question about diet. So from the point of view of weather, there's no evidence that either humidity or dry weather or hot weather or cold weather has any direct effect on fibrosis. However, I've had plenty of patients who tell me they feel better in one or another type of climate. And so I tell my patients, whatever works for you is great. I don't think anything is going to be particularly harmful for you unless you're having severe symptoms. So,
and just to talk about and add to weather, Dave, and emphasize your point is only breathe air. We've seen a lot of fires throughout the United States and a lot of fire-related pollution, and there's other forms of pollution that certainly can be monitored and you can be advised upon. We talked about ozone. There are alerts for patients with asthma. There is a suggestion that certainly those high pollutant days can affect patients' breathing, and so I would pay attention to that. We have emerging evidence that perhaps some pollution, small particulate matter and or fire and smoke associated with it, with its the fumes, may affect patients. It's research that the EPA and a lot of other organizations are doing, but I would pay attention to those and make sure that one's protected regardless if you have lung disease or not, because it can be quite irritating to the lungs. So as you said, just breathe air.
Just breathe air, yeah. So we're out of time. I'll just say on diet, there's a little bit of data on diet and lung function. The bottom line is follow your physician's directions for diet. A healthy diet as prescribed by your doctor is the right kind of diet if you have pulmonary fibrosis, and try to maintain a healthy weight. That's the end of our webinar, Greg. Thanks so much for being here. I also want to thank our sponsors, Boehringer Ingelheim and Genentech, for their support. Please visit our website, pulmonaryfibrosis.org. We have a lot of wonderful written and digital material, and you can also reach out to our Patient Communication Center at pcc@pulmonaryfibrosis.org. Thank you so much. Have a great day.